Chapter 1, Geriatric Physical Therapy in the 21st Century, Overarching Principles and Approaches to Practice. Evidence-based practice is an approach to clinical decision-making about the care of an individual patient. This decision-making process integrates three separate but equally important sources of information when making a clinical decision about the care of the patient. The figure shown on this slide shows the three sources of information. The term evidence-based practice can be misleading, making the assumption that only the scientific evidence is the only factor to be considered when using this approach. Using the literature is important, but it's not the only thing that should be used when caring for patients. So the three key elements noted in your book are best available scientific evidence, the clinical experience and judgment of the practitioner, and patient preferences and motivations. And we will be discussing these on further slides. Optimal aging theories were introduced in the mid-1980s as a way of reminding the practitioner and researchers that the typical changes in functioning observed in older individuals, aka usual aging, are quite variable and generally represent a combination of unavoidable aging-related changes and modifiable, also known as avoidable, lifestyle factors such as physical activity, nutrition, and stress management. This is really important to keep in mind, as a substantial proportion of age-related changes in functional ability may actually be reversible with lifestyle modification programs. So Rowe and Kahn in the 1980s kind of came up with these terms of successful aging and usual aging. So they defined successful aging as the absence of disease, high cognitive and physical functioning, and an active engagement with life. And then usual functioning or usual aging as some suboptimal or chronic health problems. About a decade after that, Brummel and Smith expanded the concepts of Rowe and Kahn, whereby optimal aging is more inclusive than successful aging. They define it as the capacity to function across many domains: physical, functional, cognitive, emotional, social, and spiritual, to one's satisfaction and in spite of one's medical conditions. This can lead to a vicious downward spiral, so we have to be cautious of how we term successful aging and usual aging. But the great thing is PTs play a large role in reducing negative effects of the disease process. This next slide depicts the slippery slope that's talked about in your book. There are four areas of vigor defined as fun, function, frailty, and failure. And then along this continuum of wherever the patient lands can be that slippery slope. Discussing the slippery slope in a little bit more depth, fun, that represents a physiological state that allows unrestricted participation in work, home, and leisure activities. So it's our healthy adult individual that we think about here. The next term, function. This person continues to accomplish most home and work activities but might need to modify some of their performance, but will probably substantially self-restrict leisure activities because of declining physiological capacity. The next one is frailty. This person can manage basic ADLs, but this also takes up the majority of their time. They're usually very limited in any activities they want to do in the community and require a lot of outside assistance to accomplish many home or work activities. And then the last one is failure. This person requires assistance with all basic ADLs as well as instrumental daily activities and may be bedridden. So where do PTs come in? Only 22% of older adults engage in regular physical activity based on the research. As we know, a sedentary lifestyle increases the rate of age-related functional decline with poor physiological reserve following any sort of an injury or an illness. And then as far as exercise prescription goes, I feel like who better to address this than physical therapists. We already know that exercise may well be the most important tool a PT can use to positively affect function and increase physical activity towards a more optimal aging. Underutilization of appropriately constructed exercise prescription may be associated with such factors as age biases that lowers the expectations for higher levels of function, lack of awareness of age-based functional norms that can be used to set goals and measure outcomes, and perceived as well as real restrictions imposed by third-party payers regarding the number of visits or the type of interventions that the insurance will require or will allow. Objectivity and outcome tools. As the patients age, they become much more different than they are alike. I want you to think about two 20-year-old patients. We would tend to make the assumption that they would be able to walk, drive, hold down a job, or manage sitting in a classroom all day without much disability. Now I want you to think about two 80-year-old patients. A lot of times we would think about this very differently, but possibly one might be bedbound due to years of chronic disease and generalized debility, and the other one might be out ballroom dancing every weekend with their friends. So we need to make sure that we're not making assumptions of our patients just based on their age solely. We want to make sure we know exactly where they are on the slippery slope, because again, it's called slippery slope for a reason. Is there a way that we can start to back up and improve the longevity of our patients and the ability for them to be more functional throughout their life? It's best to use functional tests and outcome measures to make sure that we have some sort of a baseline so that we know where they are today and how to appropriately set goals for them in the future. Patient-centered PT on the healthcare team. I want you to take just a moment and think about what your ideal workplace is going to be. Where do you think you'll be when you graduate in a few months? Do you think you'll be working in the pediatric setting? Maybe you'll be doing orthopedic in an outpatient setting. Maybe you want to do acute care in a hospital. Maybe you hope to do home health or skilled nursing. Because the population is growing and continuing to get older and older, and the number of older adults is really skyrocketing, the likelihood of any one of us working with the geriatric population just continues to grow larger and larger. Unless you're working in a strictly pediatric population, the likelihood of you seeing geriatrics in your facility is going to be pretty high. Doesn't mean all your patients are going to be geriatric, but you have to know that you will be working with some of these patients in your population, more than likely. Even in the sports PT fields, we're starting to see a lot more the older adults coming in because they want to stay as active as possible. Keep in mind that we become autonomous in the primary care practitioner role. Since 2013 in Kansas, we now have direct access, and that allows us to do quite a bit more than we were ever able to do previously. We become consultants, educators. We certainly talk and work with the patient, maybe their family, certainly our community. We can be researchers, case managers, and definitely patient advocates. So again, this isn't really unique to geriatrics, but just keeping in mind that most of us will work with somebody in the geriatric population during our time as a physical therapist. Just to look at a few numbers, in 2011, the first wave of baby boomers turned 65 years old. This group is definitely much larger than its preceding generation, and they're also having increased longevity. More and more of these patients are seen in all kinds of practice types. Like I said, outside of the pediatric, we're going to see them in all of our practice settings. And then a term also called like the aging tsunamis. We have individuals who are 85 and older. They're the fastest growing segment of the U.S. population. Clinical expertise and judgment. Clinical expertise is only one of the three anchors to evidence-based practice. These four dimensions listed here, virtue, clinical reasoning, knowledge, and movement, show a theoretical model to examine professional development from novice to expert. As a PT student, the dimensions are learned and used separately and distinctly, but as you become a more seasoned practitioner, you start to see these dimensions overlap. There was research done on this model of the four dimensions, specifically in the four specialty areas, orthopedics, neurology, pediatrics, and geriatrics, using board-certified clinical specialists. All the specialists were found to be highly motivated with a strong commitment to lifelong learning. Experts sought out mentors. Experts had a deep knowledge of their practice and used self-reflection regularly to identify strengths and weaknesses that needed to be addressed. The expert never blamed the patient when something didn't go right, but reflected on what could be learned and how things could go differently next time. By design, these experts also did not settle for less than what the patient's capable of doing and knew how to properly progress and push the patient to be their best. So I just want you to think about that. Make sure that we don't settle for less than what a patient's really capable of. And then find mentors and learn all you can and realize that there's always more to learn. Best evidence available. We want to make sure that we're using best evidence when we're using our clinical decision-making process like we discussed earlier in this chapter. When faced with an unfamiliar clinical situation, a clinician should reflect on past knowledge and experience, or if they have no frame of reference for past knowledge because maybe they've never encountered the situation previously, best available evidence is crucial in this situation. When utilizing best evidence available, we need to take into consideration the age of our patient, the intervention that we wish to utilize, and specific outcomes that might point us in the right direction. Seasoned practitioners can be unaware sometimes of new evidence applicable to their practice. Occasionally that can be due to just not knowing the information, and sometimes it's just due to not being willing to do the research needed to find out what new information is out there. And this is where I would say it's really important as new graduates and getting out into the workforce of realizing that there's a lot of new information that you might be privy to and have learned throughout your PT education that some seasoned clinicians just don't have access to or haven't heard of yet. And so sometimes you can open up the eyes of seasoned practitioners, allowing them to see other ways of treating patients that they might not have thought of previously. Sometimes even with seasoned therapists, just a review of the table of contents within peer-reviewed journals might be enough to spark interest and show kind of the new information that's out there. So based on our book, we have a 4-step process to apply that best evidence. Making sure, number one, that we're asking a searchable clinical question. So understanding the issue and knowing where to go find it. And there's all kinds of resources out there. Our book names some. I know that you guys have used quite a few in your curriculum here throughout your program. But just knowing where to look, and then also being open again to where new research is being done. Number two, searching the literature and locating the evidence. So just reading through it and finding out what actually is out there. Number three, critically assessing the evidence. And that is so important these days with so much information out there. It becomes information overload, and knowing how to critically assess something and know whether it's good data or not good data. And then number four is determining the applicability of the evidence to a specific patient situation. So just because something works in the pediatric setting doesn't necessarily mean that it's going to correlate and work in the geriatric population. But reading through those can also be helpful to determine what else is out there. Patient-client preferences and motivation. So this is a third information stream for evidence-based practice. I do think we need to keep in mind that we might have to help our patients truly see what goals are appropriate for them. For some of my patients, they just want to get out of pain, but if we don't really help them see what's truly possible, they might not never really see the best returns that we want for them. And more than likely, those patients will return with an exacerbation of their current situation. So we need to help them shape their goals appropriately. So making sure that we're asking appropriate questions so that we know where they really want to go in the long run, and then being able to shape those. And some of that's also based on the setting in which you work. I work in outpatient settings, so goals that I set with my patients might be very different than if you're working in a skilled nursing setting where you're just trying to work on really safety and independence in their environment. But making sure that these goals are appropriate. Did they shoot too high? Did they shoot too low? So making sure that the goals that the patient have set line up with what you know from your best practice, working with patients before, evidence, all those things that you can gather together. And then lastly, in this chapter, we talk about ageism. As discussed earlier, perception of what someone can do or can't do can really alter what they think that they can achieve. We really have to be cautious and not let our biases hold our patients back from their true potential. Some of the goals that we have for this course are, number one, to help you develop a desire to want to work with older adults, or at least understand what it means to work with this population. As I mentioned previously, so many of us will work with the geriatric population unless we're working with children exclusively. Number two, our next goal is to be able to appropriately apply sufficient intensity and specificity in exercise prescription to avoid undertreating. So knowing how to properly progress these patients and pushing them hard enough to get the gains that we really want. And then number 3 is to distinguish the important from less important details and facts during a history taking. So looking at these cartoons here, I just want you to keep in mind that, you know, the look of our patient who might be elderly and old and frail and in pain and scared about what's to come, inside was a person that was your age once, that had all kinds of hopes and dreams. And, you know, we got into this field to help people, no matter what their age or their status. And so I want to make sure that we think about everyone in that same realm as we move forward.